Hi, welcome to another session of question discussion. This is Sabna from Eduwizz Academy. In this session, we are mainly discussing the questions about lab tech or technologists who are preparing for the GCC licensing examination. We are providing a full course about these through our application with 35 hours of classes and 3000 plus questions. And this application is available in both App Store and Play Store. Not only for the lab tech, we are also providing the courses for other paramedical courses like pharmacy, nurses, etc. So, without any delay, I am going to discuss the questions, and here I take some random questions from every topics like microbiology, biochemistry, and lab management, hematology, everything. So, let's go to the questions. First question, a patient is being seen in the emergency department for a low-grade fever, headache and general malaise after returning from the Africa on a photographic safari. The physician has recorded blood for malaria. The laboratory would like to have patient information regarding. So here there is an assumption for the malarial infection and the person is traveled to the Africa. So when we are going to test, what are the informations we have to collect from the patients? The options are specific travel history and body temperature every 4 hours, liver function test and prophylaxis medication history, transfusion history and body temperature every 4 hours, and prophylactic medication history and specific travel history. So here they are already told that the person was traveled to the Africa for photographic safari. So mostly he will be over in a wildlife sanctuary. So here the chances for the malaria mostly should be a falsified. So we have to know the exact location or the travel history of this person to know the malaria is chloroquine resistant or otherwise. So we have to choose the area, the history of the travel. So we can eliminate the options number B and C. The next is the temperature for every 4 hours or prophylactic medication. In here, we have to look for the prophylactic medication because if we taken any medication for this disease or for this condition, there is a chance to decrease the amount of parasites in blood. So when we are doing any specific test like thick smear or thin smear, we will not even to see the malarial parasites. So that will leads to a misdiagnosis. So we have to know the patient have taken the prophylactic medication and also the history of traveling. So this is the answer. The D is the correct answer. So the next question, a wound specimen obtained from a newborn group predominantly beta hemolytic colonies, not the point, beta hemolytic colonies of gram-positive cocci with on 5% of sheep blood. The newborn infant was covered with a small skin eruptions that gave the appearance of a scaled off the skin. Scalding of the skin. So there is a chance for scalding skin disease. The gram-positive cocci provide catalase positive. So we have to confirm that the gram-positive cocci can be streptococci and staphylococci. So classify them into streptococci and staphylococci. We are doing the catalase test. That if the organism gave us the catalase positivity, so we can conclude it is staphylococci. Okay, so we can confirm it is staphylococci. So we have got that the organism is staphylococci. Next, we have to confirm which genus is, or which species is it, Staphylococcus aureus or anything else. So we are here they are asking for the appropriate identification test. So here it is already told that the patient have a scalding of the skin. So mostly this disease is caused by, in newborns, it is mainly caused by the Staph aureus. So we have to look for any specific tests are returned here for the Staph aureus. So then optocin bisulfite PVR, this is mainly for streptococci pneumoniae. Bacitracin PVR 6.5% for also streptococci, and CAM test is for Streptococcus agalactiae. So here the correct answer is glucose, coagulase glucose fermentation and DNase. You have to look strictly for any coagulase test. Here you can see the coagulase test on the option number B. So the answer is B. So I think you know how to get the answer correctly or how to come to the answer correctly. Okay. Then the next question, a patient's blood gas results are the following. pH is 7.26. That means pH is low. Then the PCO2 is 6 millimole per liter. So that means PCO2 is high. Then HCO3 is 29. HCO3 is 29. That means it's normal. It's about normal or slightly increased. It's normal in condition. So what will be the classification they are asking? The pH value is low, indicating it is an acidosis condition. So we can easily cut these options B and D. Here it is. Another one is the metabolic acidosis or respiratory acidosis. In this case, if pH is decreased and PCO2 is increased, that indicating it is respiratory acidosis. That means here we have a correlation between the PCO2 and also the HCO3, which is the pH, is that if pH is decreasing and also the bicarbonate level is decreasing, it is indicating it is a metabolic acidosis. And the pH is decreasing and also the PCO2 is increasing, indicating it is respiratory acidosis. I think you get the answer. In our application, I am briefly providing a class about this. If you are interested, you can subscribe the classes. So the answer is respiratory acidosis. The next question, right stain peripheral blood film 1000x. Which description best characterizes the morphology of the neutrophil shown in this plate? You can see the neutrophil. It has a 4-lobed nuclei with a high amount of granules. You can see these granules, and these granules are not normal. So this is not a normal morphology, and it is not hypersegmented because 3 to 4 are normal. Almost it is normal in some conditions, and it is not Dolly bodies, and it is toxic granulation. Not the point. This is a toxic granulation because it is mainly showing it as the azerophilic granules. You can see it is an azerophilic granules, and it is very clumsy and it is very dark. So the answer is toxic granulation. The next question, which regulatory agency mandates the following requirements for the protection of employees of clinical laboratory? PPE kit providing, the require hepatitis B vaccination at no cost, require the specific biohazard materials labeling, provide training and updating yearly of safety standards. So you have to remember, when it is come to the protection of employees that is working in a clinical laboratory, also in any other condition, the protection of employees is mainly given by the Occupational Safety and Health Administration. So whenever the question is coming up to the protection of the employee or the insurance of the employee, whatever the protection of the employee, it is provided for. The requirements are provided for. The requirements are labeled by these Occupational Safety and Health Administration, OSH. That you have to remember all the time. Okay. Then the next question, an immunology supervisor orders several anti-nuclear antibody and influenza A kit. The outside packaging of both kits was marked to store at 2 to 8 Celsius. The kits were shipped with a dry ice but were unpacked at 7 p.m. and left in the mail room at room temperature until 7 a.m. the next morning. What should be done with the kits? That means the kits are not stored at the required temperature for a long period. So what will we do at this condition? That's the question asked for the exam. Question asked here. So the options are, they can be placed into inventory. They must be tested using quality control before use and used only if QC performance is acceptable. And the kit should not be used for clinical testing. The disposition of kits depends on the manufacturer documentation for stability and the lab's load-to-load analysis. So here, when we are using a kit, the manufacturer should be given the all details about the kit. What will we do if we stored at a wrong temperature, and what will be if it is open for so many times. So they will be given us a correct usage and the proper of the discarding. Everything should be provided by the manufacturer. So when there is a condition like this happening, we have to look for the manufacturer's documentation. If they are providing any information about these type of conditions, we have to look through that first. So the answer should be the disposition of the kit. It is depends upon the manufacturer's documentation. So that is the answer. Then the next question, the patient tests positive for HIV-1 infection using a reverse transcriptase polymerase chain reaction test. However, 1 week later, and this is positive. Okay, the 1 week later, a second blood sample was collected and sent to the reference lab that performed confirmatory test by Western blot. The Western blot test was negative. What is the explain these results? The sample for RT-PCR and Western blot were not from the same patient. The RT-PCR is more sensitive for early detection. The RT-PCR results was falsely positive. The RT-PCR test detected HIV-2 and the Western blot is specific for HIV-1. So here the answer is RT-PCR is more sensitive for early detection for reverse transcriptase. Nowadays RT-PCR is very sensitive and the Western blot is not that much of sensitive when compared to the RT-PCR. Okay, so the answer is RT-PCR is more sensitive for early detection. Then the next question. A patient's peripheral smear reveals numerous NRBCs, marked variation of red cell morphology, and pronounced polychromasia. In addition to the decrease of HB and decrease of HCT value, what are the CBC parameters they may be anticipated? Reduced platelet count, increased MCHC, increased MCV, and decreased red cell distribution with means RDW. Here there is the reveals that the numerous NRBCs. So NRBC should be high, their size should be bigger than that of the normal RBCs. So here is a chance for increased MCV. You know, MCV means the mean cell volume of the RBCs. So here the RBCs, sometimes we are counting NRBCs are RBCs. So the size should be bigger. So here is a chance for increased MCV. So note the point, increased MCV. The following results were obtained on a patient's normal platelet count and function. They have a normal platelet count and function, normal PT and prolonged APTT. Which of the following disorder is most consistent with these results? Here you can see hemophilia A, Bernard-Soldier syndrome, von Willebrand disease and Glanzmann thrombocythemia. Here the three diseases are platelet disorders. These are the platelet disorders. So here the normal platelet count and function indicating that it is not a disease due to these three of them. Here in these three of them, the function should be abnormal. Not the point, the function should be abnormal. So hemophilia A is a coagulation disorder. It is a coagulation disorder. So there is a chance for normal platelets and their functions. Here is only the problem with the coagulation factor. The hemophilia A is due to the coagulation factor 8. So the answer is hemophilia A. A patient with a platelet count of 10,000 receives 1 unit of apheresis platelet, leukocyte reduced apheresis platelets, and after transfusion, the patient platelet is increased up to 50,000 microliter. That means it is increased from 10,000 to 50,000. Okay, 10,000 to 50,000. That means there is a high increase can be noted. And the patient's platelet, these results indicate the presence of HLA antibodies and refractionness to the transfusion. The patient is actively bleeding but still producing platelets. The platelet count is expected post-transfusion increment. The patient's pre-transfusion platelet count was incorrect. So here you can see an increasing in the platelet count about 30 to 40. That means 40,000 is increased. When we are introducing or when we are transfusing a platelet apheresis product, there is an increasing of 30 to 40,000 of platelets. So the answer is the platelet count is expected post-transfusion increment. It is the correct one. There is no any abnormalities or there is no any refractionness to the transfusion or HLA bodies present in this condition. If the HLA bodies should be present in this condition, there should be not an increase of platelet up to 50,000. There should be a decreasing in here, and also if the bleeding is active, they cannot be produced. They cannot be increased this amount up to this 50,000. Okay, so the answer is, it is the correct one and it is expected as post-transfusion increment. Then the next question, a 10-year-old girl is hospitalized because her urine has a distinct red color. The patient has recently recovered from the upper respiratory infection and appears very pale and lethargic. The test performed with the results shown, hemoglobin level is low, reticulate count is increased, DAT is negative, and antibody detection test is negative, but Donat-Landstein test is positive. So Donat-Landstein test positive, indicating there is a presence of P antigen or antibody P is available in our body, and here it is also indicated that there is an upper respiratory infection. Upper respiratory infection is mainly due to some infections can produce or can indicate or can elicit the autoimmune autoantibodies like antibody P, and this condition can be turned to PCH, that means paroxysmal cold hemoglobinuria. They can elicit paroxysmal hemoglobinuria. PCH hemoglobinuria is the condition that is related to the positive P cells. So here you have to remember the PCH is correlated with the Donat-Landstein test. Donat-Landstein test positive, indicating the patient is having PCH. Then the next question, the photomicrograph of fungal slide are given in the lactose phenol and the fungus, which is the fungus is this. So here you can see it is indicated that it is Aspergillus species. You can see this, structure of it. The Aspergillus have a structure like this. It is specifically for Aspergillus species. The next, an EDTA blood sample is collected from a non-fasting person for a CPC. The physician collected the sample from the femoral vein because vein puncture from the arm was unsuccessful. He called the lab 15 minutes after the sample arrived and requested a lipid study including triglyceride, total cholesterol, HDL and LDL cholesterol. Which test result should be used to evaluate the patient risk for coronary artery disease? Here we have to choose two tests that will give us a correct value about the coronary artery disease. Here you can also see the patient is non-fasting condition. When we are doing a lipid profile, we have to take the patient, the patient should be prepared, or the patient should be at least 12 hours. 12 hours fasting. The patient should be 12 hours fasting. Otherwise, the values will not be correct. Mainly for triglyceride and LDL. So here the options are total cholesterol and LDL cholesterol and triglycerides, total cholesterol and HDL cholesterol, total cholesterol and triglycerides. When we are looking for this, when the patient is not in a fasting condition, the values should be affected by the recent meals. So when we are come with the total cholesterol and HDL cholesterol, these are the two tests that is least affected by the recent meal intake. So we can go with total cholesterol HDL, that will not be affected by the meal that is taken yesterday night. So can give the level of patient risk for the coronary artery disease also. So we are choosing total cholesterol and HDL. It is mainly due to the blood collected was non-fasting sample. Then the next question, the following the transfusion reaction, urine from a patient give positive test for blood and protein. The specific gravity is 1.015, it's sometimes normal, and no RBCs or WBCs are seen in the microscopic examination. So here you can see it is test for blood and protein. That means there is a presence of hemoglobin, and there is no RBCs and WBCs and microscopic examination indicating there is no, that is not related to the kidney disorder. So here you can see indicate renal injury induced by transfusion reactions, supporting the finding of extravascular transfusion reaction, supporting the finding for an intravascular reaction, and rule out the transfusion reaction caused by RBC incompatibility. So here you can eliminate these from here, and also that means the presence of HB plus protein indicating intravascular transfusion reaction. Intravascular transfusion reaction means the blood is hemolyzed within the vascles, within the vessels. Within the vessels, the blood is hemolyzed. So there is the increased amount of hemoglobin and also some proteins inside the blood, and that is what we call, that is filtered through the kidney and it is passed through the urine. So here it is indicating, it is support the evidence for the intravascular reaction or intravascular transfusion reaction. The answer is C. So this is our the question discussion. We are done, and this is the wind up for our class. And I think this class is useful for you. And if you want more videos like this, please subscribe our channel. Okay, thank you.